course. The next speaker is Dr. Shlomovitz, and apologize for the switch in the session. He's going to talk about foam sclerotherapy for managing of the mass effect symptoms in PLD. Eran.
Okay, thank you very much, and thank you for the opportunity to be here with really some of the giants in the field. So I'll talk a little bit about STS sclerotherapy for liver cysts. We've been doing this for over a decade at this stage, and we'll present some of our own data and some of the stuff in the literature. These are my disclosures, nothing that's really relevant for the presentation today. So it's not much to get into in the background. I think everything has been discussed already. Unlike in the kidneys, where we've been doing this a lot as part of a research project to look at patients who are asymptomatic to see if we can preserve kidney function. In the liver, at least for ourselves, we do it primarily to try and control symptoms. Symptoms are mostly related to mass effect, but as was just discussed, occasionally they have IVC compression, ascites, biliary compression that we've treated in the past as well with sclerotherapy. Treatment options, again, have been discussed, medical therapy, surgery, and really us in interventional radiology, there's a couple of things that we can offer. One is cyst aspiration and sclerotherapy. And the second option is hepatic arterial embolization. It's not really in the presentation today. If there's some questions, we can perhaps discuss it as well. But certainly sclerotherapy has been the workhorse for us as far as management of these patients. This is a study that was published back in 2017, just summarizing some of the data that's been around in the past, just under 600 treated cysts. A lot of the studies that are included in this paper have looked at ethanol as the sclerotherapy agent. Ethanol is fine. The problem with ethanol is one, it's quite painful for patients, and two, as you can see, you can get ethanol intoxication because the ethanol absorbs, and we've had cases in the past where patients who were quite intoxicated at the end of the procedure and had to be transferred to the emergency department to sleep it off. So we've gone away from using ethanol for our sclerotherapy, and now primarily are using STS. That's really lowered our pain rates, and it's very, very well tolerated. So percutaneous sclerotherapy is not particularly new. It's been around for a long time. We know that aspiration alone is not enough. So you really have to destroy the inner lining of the cyst in order for the fluid not to reaccumulate. There's a lot of different sclerotherapy agents that have been described. As I said, most frequently used in the past was ethanol, but we have gone to using STS. So STS, or sodium tetradicyl sulfate, is basically a detergent, kind of a medical detergent. Very safe. It comes either as a 1% or 3% concentration. We primarily use the 3%. We don't really know what the max dose that can be used safely. It's an off-label use. It's primarily approved for lymphatic and venous malformation. So this is an off-label use of the medication. When we started, we used the approved dose, which is 10 mLs per session. And then we've increased it over the years to the point that we're now using up to even 50 mLs per session. And we don't really know where the upper limit, we can probably go much higher, but we've been kind of very gradually increasing the dose. So the procedure is done primarily under conscious sedation. Sometimes we just do it under freezing if the patient is very cooperative. We either use a trocar technique or kind of a Seldinger technique, which I'll show you kind of how it's done. And as I said, we use up to fairly high doses now, 40 or 50 or even 50 cc's of STS. And we aim to replace about 40% to 50% of the volume that we aspirate. If you over-distend them with the sclerosing, it can be quite painful for patients. So we usually aim for about 40 to 50%. So this is the technique, the way it's done. As I said, we either do a trocar technique. So this is just a small 6 French catheter. So it's about just over 2 millimeters. We sometimes trocar that directly into the cyst, or we do more of a regular puncturing with a needle and then using a wire and putting the catheter over that. This is our setup just in the interventional radiology department, typically done under a combination of ultrasound and fluoroscopy. We use the ultrasound to kind of see where we are, puncture in with a needle, confirm with contrast that we don't have any communication with the biliary tree or with any vessels. And then we put a wire in. We aspirate the fluid. And then after aspirating the fluid, we cap the drain. I think that's quite important to make sure that the volume doesn't reaccumulate, because with really large cysts, if you just leave it open, you can hear the air sort of rushing back in. And we really want the STS to come in nice contact with the cyst wall when it goes in. This is a video of sort of what it looks like. This is actually in the kidney, but it really looks the same when we do it in the liver. So I'm putting in a little bit of freezing, and then trocar goes in, and visualization is usually quite good. You can see the trocar is now in the cyst. This is the drain that we use. Has a little pigtail to keep it in place. And you form it. You'll see it form inside the cyst here, and then we inject some contrast. And we really want to inject contrast at the start, so the contrast can be quite sticky. We don't want it sort of adhering to the walls. We suction everything afterwards, and then depending on how much we suctioned out, we then sort of tailor how much foam we're gonna use. So if we're doing 2 or 3 cysts and we have 40 cc's of STS total, then we sort of divide it up based on how much fluid we've suctioned. And I'll go to the so you can see here the cyst is sort of collapsing in real time, which is very satisfying. Sometimes the patients have massive bulges in their abdomen. You can really see it coming down very nicely. This is mixing the foam. So one syringe is foam, which is just clear. The other syringe is just room air. You just swish it back and forth, and it forms a nice foam. Once you go more dilute than about 1 in 10, the foam doesn't form quite as nicely, but up to about 1 in 10 dilution, you can get very nice foam mixture, and then you inject that in. And then you can see here it's the cyst expanding when the foam is injected. So we basically cap the drain. The patients go over to our recovery room. In the recovery room, they basically turn for about an hour, kind of a quarter turn every 15 minutes. I'm not convinced that it really does anything, but it's theoretically it should coat the wall of the cyst. Then afterwards, we bring them back. We actually don't bring them back. Sorry, we just open the cap. We connect it to a drain, leave it to self-drain for about half an hour, and then after that, this is what the fluid looks like when it's being drained, and then after half an hour, we just suction whatever is left, and we remove the tube. So, unlike doing sclerotherapy for the kidneys, in the kidneys we try and go directly into the cyst, so we don't risk any injury to the renal parenchyma. In the liver, we do try and go through a little bit of normal liver parenchyma or another cyst on the way to the cyst that we're going to target. That's mainly in order to try and minimize the risk of extravasation of STS. It can be very, very painful for patients to have STS come in contact with the peritoneum. So ever since we kind of started doing that, our rates of pain have really come down. That in combination of allowing the foam to sort of self-drain for about half an hour has made a significant difference for us. We avoid cysts that are too small, under about 4 centimeters. It's just not worth it. The volume is very, very small. Cysts that are over 8 centimeters or so, we do a 2-stage sclerotherapy. So we typically leave the drain in place, let it drain over time, let the tissues collapse. Then we bring them back, we re-inject the same cyst, and we take out the drain after the second session. High-dose STS, as I said, appears to be safe. We published our data on high-dose STS back in 2022, and since then we've gone to even higher doses. And as I said, we don't really know what the upper limit is. And we don't sclerose ruptured or bloody cysts. Now, sometimes the cysts have hemorrhage in the past. In that case, we might sclerose them, but if we are concerned about an injury during the puncture itself, we won't sclerose them. This is just kind of what it looks like with the epithelial destruction with the STS. This is a study that we did. This is a pig bladder model, just trying to look at how the STS works. So you can see here pre-sclerotherapy, sort of a nice epithelial lining. And then post-sclerotherapy, basically everything has been washed off. And the entire epithelial lining has been destroyed, but really without any destruction to the underlying tissues. This is just a little bit closer magnification, and I think what you can see here is maybe the most important thing is that in the crevices where STS didn't come in contact with it, the epithelial lining is preserved, which I think is really one of the most important things. I think most of the effect of the sclerotherapy happens on the initial contact with the tissues, and you really want complete drainage of the cyst and a nice sort of insufflation with the STS in order to get good result. This is a confocal laser endomicroscopy. You can see pre-sclerotherapy, all the little microcapillaries, and then post-sclerotherapy, it sort of destroys things nicely, but without any deep damage. So I think I've gone through this. So I'll just talk a little bit about our experience. So we've done, collected data between 2014 and 2022, about 154 patients over that time, 262 cysts. The technique has been more or less standardized. As I mentioned, the largest cysts were treated in multiple sessions. This is our patient population. You can see a majority were female, as were discussed before. A mixture of PKD1 and PKD2, and majority were right lobe that we did. This is some of the results, some of the kind of larger cysts, just to show you what the technique can do. So this is obviously a massive cyst in the left lobe of the liver, and you can see on 7-year follow-up, it really shriveled down to this little tiny cyst with a bit of calcium at in the wall. It was interesting that Dr. Torres talked about IVC compression. So this is a very interesting 49-year-old female, obviously a massive cyst. I think we got just over 4 liters out of this cyst, compressing her liver quite significantly. You can see there was compression of the IVC, as well as some ascites that was formed. She was treated with sclerotherapy over 2 or 3 sessions, as far as I can remember. And you can see after 6 months, the cyst has collapsed nicely. The IVC is no longer compressed, and her ascites has resolved. So if you, these cysts require more than 1 session, but you can really get pretty dramatic results. This is just some of the experience in the kidney population, but the appearance tends to be the same. You can see the effect is persistent over the long term. The cysts that were treated don't tend to re-expand after they've been sclerosed. This is again just showing you the progression of the effect after treatment. So these are our results. So we can get a mean volume reduction of about 82%. Interestingly enough, this seems to be a bit lower than what we can get for kidneys. When we treat the kidneys, we can get 90–95% volume reduction. In the liver, for whatever reason, the volume reduction tends to be a little bit lower, but still, very effective. You get volume reduction essentially 100% of the cysts. In 91% of them, you can get over 50% volume reduction, and only a minority of them you get less than 50% volume reduction. Sorry, this is looking at single stage versus 2-stage. sclerotherapy for these cysts. So in our experience, we didn't see a significant reduction in volume if we do one stage versus two stage. Although you do have to keep in mind that in the two stage sclerotherapy patients, the baseline volume was obviously much higher. So 400. 480 cc's versus 176 cc's for the ones that had two-stage sclerotherapy. So we still advocate for the larger ones to do at least two stages. Volume response versus cyst size. So interestingly enough, regardless of if it's a small cyst or a very large cyst, they all get that sort of 80 to 90% reduction in volume. And then STS volume versus concentration. So again, we didn't see a significant difference on sort of how much STS we use or what concentration of STS we use. And again, I think it's mostly a function of if you create good foam and if it comes in contact with the wall of cyst, then the exact concentration of the STS doesn't matter that much, at least in our experience. Volume response versus mutation, no significant difference between the PKD1 and the PKD2 mutation, but for whatever reason, a little bit lower than the response in the kidneys. So long-term follow-up, we had 119 cysts that we were able to follow up more than a year. Some of them up to over 1,000 days. And interestingly enough, if you follow them more than a year, you still get some additional shrinkage beyond the initial effect as it sort of scars down. So the vast majority you will see continued reduction and certainly no evidence of re-expansion, at least in our data. The procedure tends to be very safe. It doesn't take a lot of room time. Usually you can see the fluoroscopy time just under 2 minutes. The patients are typically in the room for maybe about 20 minutes or so, depending on who does it, how many cysts, if you have to go 2 lobes or 1 lobe. So the procedure is quite quick. You can do it under ultrasound alone if you wanted to. Technical failures tend to be pretty rare. We've had some cases that we've crossed the hepatic vein on the initial puncture, in which case we didn't sclerose and just pulled out the drain. Nothing else needed to happen. Cyst rupture can happen. If it ruptures, we just don't sclerose them. If we see any communication with the biliary tree, we don't sclerose, but that's very, very rare. Usually a kind of a technical issue. We had 4 sort of minor complications with bradycardia and some instances of pain. And then 1 complication related to a suspected cyst infection. I think you have to be careful when you kind of call these cyst infections, because we do see patients come in with pain and almost like an inflammatory symptom, especially when you treat these really large cysts. You have a lot of raw surface that's inflamed, and occasionally they can come and seem as if they're infected, but cultures have been negative. We've actually aspirated fluid, and cultures have been negative. We, from our experience in the kidney cyst, and I didn't include that slide, but we've had 1 patient that we're actually able to track by ultrasound every 2 days. The patient is actually an ultrasound tech, so he came in and ultrasounded himself every other day after sclerotherapy. And what actually you see is that the cyst sort of goes down. The volume goes down immediately, but then there's a little bit of re-expansion, probably related to sort of inflammatory response, and then it goes down again and then disappears. So you do get this inflammatory reaction when you treat these large cysts. So in conclusion, STS I think is very safe and effective. You can treat very large cysts. You can target patients who've had ascites if you can target the cysts that are sort of pressing on the cava. Obviously not possible in every instance, but if there are some cysts that are contributing, you can try and target them. And then our long-term results show that the effect is persistent, and the procedure seems quite safe and effective. Thank you very much.
Thank you, Eran.